My name is Holly Spooner, and I'm currently studying nuclear medicine at the University of Newcastle. This poster presentation is a case study involving 18-FDG PET-CT and the idiopathic disease process known as sarcoidosis. This 38-year-old male initially presented to a nuclear medicine department in October 2017 with ocular symptoms, rash, postural presyncope, fatigue, and weight loss. The patient's recent history included renal cell carcinoma, which resulted in a right nephrectomy. Following a recent chest X-ray that showed aberrations throughout the respiratory system, a biopsy of the site was conducted. This biopsy failed to collect samples, so further investigation through PET-CT was pursued. Figures 1 and 2 are both 18-FDG PET-CT acquisitions, acquired 2 months apart. In the neck, chest, and upper abdomen in Figure 1, there is FDG-avid lymphadenopathy, which is favoured to represent sarcoidosis. The intense FDG uptake in the chest is seen in the enlarged mediastinal, bilateral hilar, and pericardial lymph nodes. The patient was placed on a course of corticosteroids and had repeat imaging 2 months later to assess the response to treatment. This is a reliable treatment option in providing symptomatic relief and reversing organ dysfunction. Figure 2 is a follow-up PET-CT image 2 months after the patient started his course of treatment. Compared to the previous examination, there is reduced uptake in the right axillary, multiple mediastinal, and epicardial nodes. The hilar nodes are still avid, but have decreased in size. This is a strong indication that the patient had sarcoidosis over metastatic disease, as there has been a positive response to the steroid treatment. In 2021, 4 years after the original diagnosis, the patient presented with similar symptoms and increased calcium levels. The differential diagnosis suggested that it was either metastatic disease from his previous renal cell carcinoma or recurrent sarcoidosis. Therefore, the patient was assessed by another 18-FDG PET-CT. For this examination, the patient followed a keto diet, which shifted the myocardial metabolism to fatty acid and suppresses glucose utilization. This effectively reduces glucose uptake by normal myocardial cells, which helps highlight if any disease has spread to the myocardium. Figure 3 highlights the infective process of sarcoidosis in the mediastinum, hilar, and upper retroperitoneal regions, with no avid cardiac uptake to be noted. The patient was placed back on a course of corticosteroids before the thoracic sarcoidosis turned to fibrotic scarring. Overall, PET imaging played a vital role in determining the extent of sarcoidosis in this patient and effectively assessed the response to treatment.